So when we talk about identifying medical arrest or traumatic arrest, the point here is you guys have to try to figure out and filter the information to determine which came first, the chicken or the egg. Did the patient have a cardiac arrest event because they have a pulmonary embolus or because they had an electrolyte abnormality and they went into a cardiac arrest and that caused them to crash their vehicle? So you get there and maybe they've hit a telephone pole or a parked car, but there's minimal damage. The bystanders are saying they were only going about 10 to 15 miles an hour. That's probably not going to cause somebody to have a traumatic arrest. If you get there, though, obviously the mechanism of injury is going to play a big portion into this. And if there is severe damage to the passenger compartment, there's another death in the same passenger compartment, then obviously our index of suspicion is going to be raised a little bit so that we can try to figure out why this patient is in a traumatic arrest, because what we're going to look at is the treatment is going to be different between the two, and that has historically not been the case. Having done this for several years at this point, what we typically would do is the patient is in cardiac arrest. Okay, we follow American Heart Association ACLS guidelines. We initiate resuscitation attempts, and then we transport them ultimately to a trauma center if it is an individual that we feel is going to be transportable. If it's something that it's an obvious death or we have more patients than we have resources, then clearly, maybe that's a situation where we would pronounce this particular patient and then just make sure that we're documenting everything appropriately. So when you arrive at the scene, determining the arrest cause or etiology is one of the biggest things that you're going to be able to do to help guide the proper treatment for that particular patient. So look for clues on the scene, other injuries to the body, et cetera. And does the mechanism of injury match the level of injury or the cause of the arrest? So what I think is important here, though, is once you have determined that this patient is in an arrest situation, and we think that it is not medical, right? So you either find them in a car following an accident, or there is some evidence to go along with the fact that the patient is in a cardiac arrest. We really need to look at the rhythm first of all. So if the initial rhythm presents to you all as VFib or pulseless VTAC, that is telling you that the cause for this patient to go into cardiac arrest is most likely going to be a medical condition. If they are in a traumatic condition, they will not go into VFib or VTAC. Most of the time, what they're going to end up in is either PEA or asystole, and that is because of the hypovolemia, the blood loss. So once the patient starts to use or lose all of their circulating blood volume, they're not necessarily going to go into a VFib or a VTAC. What you're going to find is they're probably going to go into a PEA initially. And then if there aren't corrective measures that are taken in a pretty quick manner, then that is going to end up progressing into asystole and then traumatic arrest. So there was a study done by Morrison and others back in 2015. So a little bit outdated as far as the data. We like everything to be within 5 years if possible. From a medical oversight perspective, all of the studies that we're referencing, we try to do within the last 5 years. There's another one today from either 2004 or 2005. So occasionally there are things that are outside of that. And in that particular situation, quite a bit outside of it, but we felt that the information was important from back at that time. So we're going to talk about it today. So this particular study that was done, it was a small sample population of only 65 patients that received resuscitative thoracotomy. And what they had was a total of 14 survivors, 21.5%. So 14 out of 65 of these patients ended up surviving after a resuscitative thoracotomy. But the arrest rhythm, which is what we're talking about here, about 40% of that, 38.5%, was an unknown rhythm. So they didn't know, based on the EMS dropping off to the receiving hospital, what that initial rhythm was, or it did not get relayed. If PEA was the presenting rhythm, though, 92.9%, so 13 out of 14 of the folks that ended up surviving were found to be in an initial PEA. And we have always kind of just blown PEA off because it falls within that asystole algorithm. So we kind of just say, PEA and asystole, these are injuries incompatible with life. This is going to be a futile attempt, things that I have said personally in the field. And we're finding that that may not necessarily be the case. So we're going to look at PEA a little bit deeper than what we have done previous. So why would PEA at 92.9% survivability, why would we write that off? And the answer to that is really because we don't know if the PEA is actually perfusing the individual or not. Yeah, we're not able to feel a palpable pulse. And even back to EMT class, if you had a radial pulse, it was thought that you had a blood pressure of somewhere around 90. If you had a carotid pulse, it was somewhere around 80, femoral pulse, somewhere around 70, and those are systolic numbers. But what we don't know is what kind of perfusion the patient is actually getting from that low output. And that is why it is so important that if we are going to work these traumatic arrest patients, PEA are the individuals that we really need to be thinking about resuscitative efforts and then quick transport to a hospital so that they can receive appropriate care. So we're going to talk about the trauma triad of death one more time. There's 3 different sides to this triangle: hypothermia, coagulopathies, and then acidosis. And we're going to look at each one of these as it relates to traumatic arrest. So coagulopathies, first and foremost, there is something called DIC, or disseminated intravascular coagulation, or coagulopathy, and it happens in patients that are having a traumatic event. So what ends up happening here in this situation is these clots, there are microclots that end up developing, and they can start to occlude small blood vessels that lead to the vital organs. So if we have clot formation in those small vessels and there's not oxygenated blood that's getting to the vital organs, which are going to end up being the heart, the brain, and the kidneys in most of these situations, because that's where blood is going to get shunted to. And then secondarily to that, it ends up triggering the systemic inflammatory response. So they're going to have a release of chemokines and cytokines and all those helper messengers that are going to end up going to that area to try to cause a repair. And what ends up happening is they end up with a bigger inflammation, more swelling, and then it ends up causing acidosis. So there are a lot of problems that go along with patients that are bleeding. The other thing here is, if we're talking about microcirculation and microclots, all of your platelets and clotting factors rush to those same areas, and that happens in that systemic inflammatory response. So what I want you guys to think about is you have a patient that has been traumatized and they are bleeding, and when those clotting factors and the platelets start to rush, and they end up blocking off the blood supply to those vital organs that we've mentioned, they are no longer available to stop the bleeding at the site of injury. So what ends up happening is these patients, it really ends up becoming a cyclical thing. There's clot formation, which takes all the platelets and clotting factors. The problem with that is there's not enough platelets and clotting factors to stop the bleeding at the site of the gunshot wound or the stabbing or the head bleed, whatever the situation may be. So the patient continues to bleed even though they have an excess of clotting. It's just in the wrong spot, and that is where the problem lies. This is going to result from hypothermia and acidosis because they end up losing the clotting factors. And also, we can actually create this by giving them a dilutional anemia. And the way that we do that is by giving too much fluid. So again, I feel like I should say this. I'm not here to recommend or suggest that you change the way that you operate as far as your protocol is concerned. But what I will mention to you is sometimes it's beneficial to call and find out, hey, what do you want me to do? And it actually, I think, gives the physicians on the other end a little bit of boost in your abilities, that you're actually thinking through some things instead of just, okay, this is a trauma patient, I'm going to start 2 large bore IVs and give them fluids wide open. We know that that may not necessarily be the best thing to do because of this dilutional anemia that we're creating by giving them too much fluid. So once we start that process, it ends up leading into this disseminated intravascular coagulopathy, And that is one side of this triangle that we need to be familiar with. The second one is hypothermia. You know, back into EMT class, I can recall patients that are traumatized can be hypothermic even on a hot day. That is very, very true. And here's a study that I was referencing back in 2004. Approximately 50% of patients that were transported by EMS had a body temperature of less than 96.8 degrees. That is hypothermic. It is close to being the 98.6 that we think is going to be normal, although that actually just kind of raised a little bit. They've changed what the normal temperature is as far as the standard is concerned, but not much, and not what we're talking about today. But 96.8 degrees is pretty hypothermic. You actually lose your ability to shiver at 96 degrees. So now we're talking about a patient that is really getting into some moderate to severe hypothermia. Why are they like that? And it's simply because we are not managing the patient appropriately. We've got to cover them up. We have to turn the heat on. We have to get cold, wet clothing off of the patient. So anything that we're going to be able to do to try to maintain that body temperature is going to be of benefit to the patient as far as this trauma triad. So what ends up happening here is the patient initially has the ability to shiver until that temperature drops below 96 degrees. When they are shivering, we know that it causes an increase in oxygen consumption, which makes sense. Your muscles are using more oxygen. The shivering is trying to generate heat. That is why we shiver. When that happens, though, however, we end up having a reduction in cardiac output, which leads to myocardial ischemia. So if we're dropping our cardiac output, and we know cardiac output is related to stroke volume times their heart rate. So how much blood are they actually able to eject from that left ventricle? That's your stroke volume, and it should be around 70 or so per ejection. And then we have to multiply that by the patient's heart rate. So once we know what that number is, we can figure out what our cardiac output is. But if we have patients that are hypothermic, their cardiac output is going to drop. And that is exactly what we don't want to happen. We want their cardiac output to be able to produce a mean arterial pressure of somewhere close to 90 or at least above 60. And we've talked about mean arterial pressures in the past. So did the accident expose the patient to hypothermic conditions? So you may be up against the 8 ball before you ever start taking care of the patient. Was this a car crash in the middle of the night in winter where the patient has been there overnight and their core temperature is already hypothermic? If that is the case, then again, active rewarming, we need to try to really make sure that we're keeping their body temperature to an appropriate level. And then the third part of this, or the third leg, is the acidosis. So we can recall that your pH, a normal pH is 7.35 to 7.45. And if it is less than 7.35, these patients are acidotic. And I want to stress this. The pH scale is a logarithmic scale. So what we will often find is when we're talking to students about acidosis and how to determine ABG, arterial blood gases, they'll go, well, it's 7.34 and that's close. You know, close counts in horseshoes and hand grenades, as the old saying goes. It does not count as far as pH. So if you have a patient that has a pH of 7.34, that patient is acidotic. On the opposite side, if it is 7.46, that patient is definitely alkalotic because of the logarithmic functions of that particular scale. So if you have this ability, and some of you have asked for lab value interpretation, if you have the ability or you want to look at these numbers, the range should be 735 to 745. And if it is not, they are definitely acidotic. Why does this matter? It all goes back to this trauma triad. So it's going to cause a decreased cardiac output, which we know is going to have a resultant decrease in blood pressure. It decreases the threshold for ventricular fibrillation. It causes an inability of the body to have that clotting cascade. And when we don't have all of these things, we don't have enough circulating blood volume going around. So now we don't have the ability for oxygen to bind with hemoglobin. So they're also becoming hypoxic and they are not getting the appropriate oxygen to the various tissues. So Hopefully, between the three, hypothermia, coagulopathies, and acidosis, you guys are starting to understand it is very, very important to make sure that we are trying to manage their blood pressure to an appropriate rate, which is going to end up being somewhere around 90 systolically, permissive hypotension, and we've got to keep them warm. If you all can do that, then your patient is going to have a better chance of surviving this particular insult. The fourth thing here, so we've added one in. So another thing that I think is important for you guys to keep in mind is when patients are traumatized and they are hypovolemic, what do we often want to do? We want to give them blood. Well, we may not have that ability in Northern Kentucky, but certainly EMS agencies throughout the country do. And definitely when we get this patient to university or children's hospital, depending on age, they too are going to try to give blood as quickly as possible. Well, the thing with blood is this: the blood gets donated and then it sits on a shelf, okay, in some sort of a cooler. It has to be kept at a certain temperature, but they add parts to that blood to keep the blood from actually spoiling, all right? If you'll just kind of think of it like that. We want to make sure that when the blood is needed, it is able to be administered and it's not going to end up causing problems for the patient. In the typical range of blood that can be kept is around 35 to 42 days. So if we're inside that range, we want to make sure that the blood is appropriate and that it is not going to end up causing problems for the patient because there has been growth of bacteria and so on and so forth inside the blood product itself. So the way that they combat this in the blood banks is they end up adding something called citrate. So they take the blood that has been donated and they put citrate in it. And what the citrate does is helps to keep the blood basically at a level playing field to where it doesn't spoil. Well, citrate ends up binding with calcium and it inactivates the calcium that is in the body. So when they start administering this blood to the patient, it's going to end up making the patient hypocalcemic. And that is because of one of the additives to the particular blood product that is trying to keep it good. So again, we have to be aware of that. And not that we're going to do this in the field, but certainly if you hear them talk about we're going to hang blood and also think about giving the patient calcium or calcium gluconate, that is the reason that they're doing it. We're trying to make sure that their calcium level is in an appropriate range, which should be somewhere between 8 and 10, depending on the lab. The calcium level blood calcium level should be somewhere between 8 and 10. So if the patient is receiving blood concurrently, they should be also receiving some sort of a calcium, or at least making sure that they're getting serial labs drawn so that they can determine if the patient is in fact hypocalcemic. So why does that matter? Well, it matters because the studies that have been done, patients that end up dying from cardiac or traumatic arrest related to hypovolemia that are receiving blood products are also found to be very, very hypocalcemic. And they think that this is actually adding to some of the issues with the increased mortality. And it makes sense. Calcium, if you're not aware of what calcium does, it does a few different things, but we have to have calcium available for our cells to fire appropriately. And if you don't have enough calcium, then the cells aren't going to fire. So that is going to affect muscle in particular. And the most important one is going to be the cardiac muscle in this particular situation. So again, just something for you guys to kind of think about, and the why as to what we're doing and why they're doing the things that they do in the trauma centers. So how do we fix the trauma triad? We've got to stop the bleeding. We have to manage the airway. We need to make sure that the patient is warm, and we have to try to prevent shock. So if we can start at the top one here, stop the bleeding. So years and years ago, when I was working at UK, we were terrible as part of the air medical program about stopping the bleeding. And we actually kind of got ripped pretty good in one of our staff meetings by one of the trauma surgeons. He was upset because, you guys are really good at your skills and managing the patient, but they come into the emergency department and they're still bleeding. And the reason that we do that is because we're so focused on either the injury looks bad, wow, that is impressive, or I got to get this tube, or I've got to get this IV established, or whatever the situation is, that we're really not paying attention to the fact that the patient continues to bleed. What they did for us was gave us a staple gun. They told us, we're going to give you a staple gun. We don't care if it's pretty. We want you to staple the wounds, stop the bleeding. And then ultimately what ended up happening is they would remove those staples and then either redo it or suture the patient in the hospital. And they did that. And it really sent a message to us that, okay, if they want us to staple these patients in transport, they're really serious about this, and they should be. We have to stop the bleeding. Managing the airway, undoubtedly a very important thing, and we can do that either through intubation or the use of supraglottic devices like an iGel, which most of you are probably using in today's world. Keep them warm. So turn the heat up in the back of the medic unit. I do not like hot weather. I do not like to sweat, but in these situations, it is what is going to benefit the patient the most. So make sure that the temperature is warm and that we're covering the patient up with blankets and sheets or whatever you have available to you to try to maintain body temperature. And then prevent shock. So if we can keep their pressure somewhere around 90 systolically, and we can do that through a few different things. We can put them Trendelenburg, or we can try to give them some fluid boluses, but we need to make sure that we're not overdoing that and causing that dilutional anemia.